Our patient's HbA1c is 8.2 and she has a glucose level of 168 milligrams per deciliter, both of which are elevated. Likewise, presence of glucose in the urine leads us to a diagnosis of diabetes mellitus type 2. The laboratory results of the patient, combined with her medical history and physical examination, are all pointing to a diagnosis of diabetes mellitus. An A1C of 6.5 and above, as well as a glucose level of 126 milligrams per deciliter and above, are diagnostic of diabetes mellitus. Diagnosis requires two abnormal test results and such as A1C and glucose level. Before, the only treatment options for diabetes mellitus are lifestyle modifications, sulfonylureas, metformin, and insulin. Now there are almost 40 medications that we can choose from. As family nurse practitioners, we should treat the totality of the individual, not just managing the blood glucose level, insulin resistance, and islet cell dysfunction. We should help them reduce their risk for myocardial infarction, stroke, amputation, chronic kidney disease leading to dialysis, and premature mortality. First line of treatment will always be lifestyle modification which includes weight management and physical activity as well as metformin. In our patient, aggressive management may be needed as she is already having the complications of diabetes like diabetic neuropathy and beginning cardiac disease as seen by an early LVH. Patient may be placed in insulin therapy therefore. Monitoring diabetes and patient education should be emphasized. Assessment of glycemic control is through monitoring the patient's A1C. The patient can self-monitor her blood glucose levels, but this is usually directed towards insulin adjustment. Quarterly monitoring of A1C is needed to measure patient's glycemic targets. Our patient has diabetic neuropathy as it causes pain and paresthesia on her feet and possibly hands. Treatment goals are to restore function and pain control for our patient. As NPs, we can support our patients' primary care practitioners and can help improve the clinical outcomes of our patients by helping them lower their HbA1c. This is done by supporting follow-up care through office visits coupled with electronic visits and telephone visits. We can initiate treatment, change, and adjust medications.